Welcome to week 2 of the Field Training Officer and Preceptor course. This PowerPoint is going to be, and this module is strictly going to be documentation of the person's performance. There is actually going to be 2 chapters in this particular PowerPoint. There's more than one way to do something, summation, and then the actual critique form. There's more than one way to do anything, and there's always, and the problem that we run into with EMS is it's your way, my way's the right way. And that's not always true. So just keep an open mind when you're watching these people in their observation phase. You just want to remember, maybe they learn things a little bit different. Maybe their mind works a little bit different. And just watch them. It could be a regional thing. It could be any number of things. Now, there are some things that are wrong, and you're going to have to intervene with them. Again, you got people, you got a different type of instructor just from county to county sometimes. The age of the clinician, you may have a very young student or a young new orientee, new employee orientee that has been around in EMS for decades, and some of the older staff it's harder for them to get those things out of their practice. Life experiences, our personal life experiences are the life experiences of that person that you're evaluating. If this is experienced paramedic or experienced EMT, maybe you notice that they almost have, when certain things come along, they almost kind of have a certain specific ritual, for a lack of a better way to describe it, that they do stuff. Well, if you get to asking them, it's probably something that happened to them years back on a call, or maybe it's just something that an instructor taught them. Same thing for us. There's certain things that I do as a paramedic that not other paramedics do, but that's because of where I came from. It doesn't mean that it's any more right than anybody else. It just means that is my way of doing things. FTOs need to remember that every provider is in fact unique. Like I said earlier, everybody's got a different learning style. Everybody's got a unique way of approaching things, and we just need to kind of sit back and watch, and let's see how they do what they do. Techniques, performing skills may vary from person to person. Now, I'm going to say this. When you are looking at skills and you see this student do something that is obviously not within standard practice, you need to provide them feedback with that. If you are teaching them how to do a shortcut, then you are legally liable for teaching them how to do a shortcut if it varies from the standard of practice. So just remember that. If you're watching them do something and that doesn't conform to the standard of practice that is within, that would be nationally accepted, that any other paramedic in the region would or wouldn't do, then you really do need to address that. And you kind of have to use your judgment as when the best time to do it is going to be. FTO should not penalize based solely off differences in techniques. I've watched people when they start IVs. Not everybody uses a tourniquet for every type of patient. Is that wrong? No, it's not wrong. Did they get the IV? It just kind of depends on the patient. There are some people who really do not use tourniquets on elderly patients when they're starting IVs, and I understand the logic behind it. That's not a bad thing. That's just something that maybe they've learned through years of taking care of patients. Now, it could be that they just got excited and forgot to put the tourniquet on. So it can go both ways. Don't interrupt them unless unless what they're doing is unsafe, too slow, or outside of protocol for your agency. If the student performs the skill in a way that is timely, safe, and within the standard of care, just let it go. That's what I just said that earlier. And one of the things that I'm going to get on is I've seen out in the region people actually inserting a bougie into an endotracheal tube and using it as a stylet, and that is inappropriate. You should, if you were to see a paramedic student using a bougie as a stylet inside of an endotracheal tube, that's you, you know that's a big deal. If they put the bougie through the vocal cords and then thread the endotracheal tube over the bougie through the vocal cords, that's appropriate technique, and that's the way it should be done. So I've seen that a lot out in the region, and I don't know where that's coming from, but that's just one of the things that I can think of right off the bat. That is something very unsafe, and that actually causes a high increase of airway misses. By allowing the student to perform the task in the incorrect way, or an unusual way, the FTO's agency can be strengthened. All right, so let's say that they're doing it right, but it's not something you've ever seen. Just sit back and watch. Take note of it and go back and look and see if if that meets national standards. If it doesn't meet national standards, then we need to address it. There's always more than one way to fix a problem, as long as it doesn't violate any ethics or standards of practice. Then let them go for it. By us seeing, trying, or incorporating new techniques, the performance level of seasoned providers may improve. Again, providing that it doesn't go against standard of care, standard practice, and doesn't cause any harm. You don't know everything, although some paramedics think that they do, some EMTs think they do. We don't know everything. You should learn something new every day, and that is something that my grandfather taught me years ago. That every day you get up, you should make an effort to learn something new. If you didn't learn something new, ask yourself why. And the day that you stop learning is the day that you should retire. And that is a absolute true statement. At the time and the day that you know everything about EMS, about patient care, then you should leave this profession. I've personally been doing fire and EMS for 32 years. And there are still things that I learn each and every day. This is an ever-changing environment. Things change every day. All right, so the critique form. It is a tool for documentation. Now, this is a generic critique form. And you've seen in your update for your FISDAP, you're going to have something to do on that. And there also may be a form specific to your organization, your EMS agency, or maybe through the community college. So you need to look at that and become very familiar with it. Now, this is a generic critique form, and that will kind of give us the idea of how we need to go. So the first part of it is basically the student's name, where they were at, the date, who was the preceptor, the run number, so we can tie it back to an actual run number. Now, reason this is all important is there are students and new employees, unfortunately, who will falsify their encounters, and we need a way to tie those encounters back. So make for sure that there's a run number on it. Me as a paramedic instructor, I do not take any forms from the field that do not have information that I can tie back and audit those runs. Make sure that, because what you may also get is you may get students who are trying to, while they're on shift, they may be a full-time employee as an EMT or an advanced EMT, but going back to paramedic school, or an EMT trying to go back to advanced EMT school, and they're actually documenting the runs that they do while on duty, and that is not acceptable, not in the state of North Carolina. What was the age and sex of the patient? What was their chief complaint? How did they present? And reason we want to know that, again, we're tying all this back to make it relevant and to showcase if something ever happens and this person's training ever gets called into question, and it can be. That's one of the things that will happen sometimes with some of these injury lawsuits where a paramedic has made a bad decision and hurt somebody. They will actually go back and pull that paramedic's training record, and if that paramedic is relatively new or at the time when the incident occurred, they're going to go back and pull these precept forms. So again, be honest, be objective, and be honest. The critic form is going to vary based off of what's going on. Are you just observing the patient or the employee? And the scoring of each phase is going to be dependent. The rules need to be set up by your organization, i.e. the college, or by EMS. Now, how they're scored is based on the expectations that have been already established by that paramedic instructor, by the advanced EMT instructor, by the EMT instructor, by that organization. So they should know coming out of the gate how they're going to be graded in each phase. Now, they may go into observation phase and also be in remediation, and that's going to be something else. So observation phase, again, is defined through your organization, how you're going to grade them. Usually what will happen is we'll start off showing them how to do stuff. We're going to grade them in how reactive they are in watching us as a instructor. And there's going to be kind of a handoff there where we're going to stop allowing that student or new employee to watch us, and we're going to slowly phase them in, slowly implement them into that equation, and just watch to see how they handle the increased task, increased responsibility. If they're in remediation, which honestly, when you're starting off as a new EMT or new advanced EMT, whatever, you're probably going to go in the observation phase, remediation phase, observation phase, remediation phase, kind of back and forth until you get mastery of whatever it is that you're trying to learn. During that time, you're not really going to be scored as a team leader, because if you're in remediation, then obviously we're looking at certain specific skills. Maybe your patient interview is the problem. So we can't judge you as a team leader because you're still learning how to do patient interview. We can't judge you on the whole scene management aspect of it when you don't even know how to manage that one patient. So just take the fact that knowing that you're not going to probably be doing a team leader score on them whenever they're remediating on something. The FTO will usually circle team member on a critique form. This usually indicates that the student is one of the students that this is a student that is just functioning as a team member, and they're only responsible for the assigned skills. For example, today we're just going to practice doing airway management, or today we're going to practice IV starts or assessment, whatever it is that you've assigned for this person to do. That's the only thing they're going to be responsible for. So make sure that you document that on your critique form. Once the student has gotten a big part of their skills or assessment, and you start wanting them to kind of put it all together, that's when they're going to go into the team leader phase, and that is going to be where you score their overall success rate. They must achieve 6% success rate, 6% on a minimum number of patient contacts. For example, 25 with a high priority, or who have some relative significant medical emergency, chest pain, difficulty breathing, altered mental status, that kind of stuff. Um, so once you get past 60%, you're then going to then step up that requirement and they're going to go from 60% to now 75%. And again, there's a minimum number here. It can be 25 patients, it can be 15 patients. A lot of it kind of depends on your call volume. 25 seems to be a good number. If they're consistently doing 75% success rate on 25 patients, they're probably going to do that the rest of the time as well. All right, the critique form reminders, it serves as reminders for the FTO. You can circle, for example, you had to prompt them to check a blood pressure or speed up. Just make check marks. Those are things that will help you out as far as kind of keeping on track. So each competency group contains a number of skills that are related in a similar way. You are the FTO, so for example, you've responded to a call for a man down in front of a bar. You prompted your student to put on gloves. A little bit later in the call, you prompt him to have the partner drive the unit around the corner, get out of line of sight of a rowdy crowd. When would you begin to document these prompts, and what would you do? So this is an example of that documentation. Now there's two things to this. You're going to document this, and then there's going to be a time at the end of the shift that you're going to have to go back and do a summation evaluation of that person's activities for the entire day, for all of the calls, and it needs to be documented that you have addressed that and what your plan of action is with that person. There are different types of prompts. There's an inadvertent prompt, and then there's the teaching point. Each prompt is part of the patient's score, and the score is based on the number of prompts given by the FTO during that patient contact. Sometimes although a prompt isn't really a prompt, we all are human, we forget stuff. Inadvertent prompt is one that was not intended to be given. Some will be counted and some will not. And there was a video, I want to say it's back in the 40s, of a guy who got a donkey. I think it was a donkey. And he swore up and down the donkey could count and do math. And what they found out is the owner of this donkey was actually giving inadvertent prompts showing the donkey how many times to tap his hoof. When they put a separating wall between the owner and the donkey couldn't do math anymore. And I'm not by no stretch saying that our students or our new employees are donkeys, but I'm just using that as an example. We can give inadvertent prompts and not even realize that this guy who owned that donkey had no idea he was giving prompts. It just, whenever he went back and was shown the difference, it totally made sense, and he could see where he was actually tapping his foot. The donkey would watch the man tap his foot, and he would tap his foot that same number of times. Interactivity. Examples of inadvertent prompts. Zipper on the zipper bag. The FTO partner says, "Do you want me to get a blood pressure?" And the patient says, "This is like the time I." So these are some kind of examples of how we may prompt this person to do something, to put the patient on oxygen, or to do whatever, because we just automatically, we're in partner mode and we just start doing something. And if you recognize that you've done an inadvertent prompt, document it, because it all makes sense. If you do an inadvertent prompt on a weak employee or a weak student, they may not recognize the fact that, or you may not recognize it, or they may get credit for being able to think more independent than what they actually are. So document it if you realize that you've done it, and that way you're covering yourself, and you're actually, believe it or not, actually covering that employee. Neither a prompt nor an inadvertent prompt, as far as a teaching point goes, is defined by nice to know versus need to know. The FTO misses something important. Yes, we can miss something important. Or the FTO prompts a little bit too early, or is not counted in and is not counted in the student score. Some prompts may be neither, again, maybe neither a prompt or inadvertent prompt. They just, as they are, like I said, they're teaching points. The FTO asks the patient who his family doctor is. He later explains that this was a teaching point for the student. This information was about the family physician. That will be helpful when we get to the hospital, because some of the most all of our patient records are now electronic, and we can now pull them up through a variety of ways into the hospital. Although the patient was treated for an acute coronary syndrome, the F2 asked for a recent fever to help rule out chest pain that might result from an illness or inflammation. That does happen. Frequency is used for non-essential care, but the FTO wants that student to include that question on all subsequent chest pain calls. On the other hand, you may ask about erectile dysfunction and if they take medication. And this is a very good teaching point. Unfortunately, it's not asked correct time by either the student or FTO, and this makes the prompt for a teaching point. Most of the time with that, we all know if any, that's kind of one of those things where some people, you ask that out in public, they're not going to be ashamed to admit that. But whenever you're about to give nitroglycerin, you have to learn how to do that in a very discreet way. For example, someone passes out at a public event in town. You have to teach, the FTO has to teach that student or that employee how to go about asking that information without being advertising it throughout the whole group of people that are there. All right, use check marks to document the skills performed by the student. This is in this particular check sheet or critique form. Your critique form may be a little bit different, but you kind of get the idea. If it's checked, it was done. The FTO assigns or has assigned a satisfactory score of 3 to the student's performance in the competency for protocol application. Again, that goes back to how you've got your grading system set up. That score of this one in this particular example was satisfactory. FTO circles prompt and the skill to indicate a prompt was given and on what behavior. The FTO uses check mark to document the correct performance. You will also use this critique form to document inadvertent and teaching point prompts. Again, assign a score in each competency group. At 5 minutes of elapsed time, the FTO prompted the student to reassess the achieved complaint, the blood glucose level, and the patient heart rhythm. The FTO scored a 2 on this scenario because his reassessment was satisfactory, but there were too many parts of this that the FTO had to provide prompting on. And you want to add some kind of notation there so that you'll understand why. And you notice that he actually put in a elapsed time 5 minutes. So that meant at 5 minutes he had to prompt this person to redo his assessment. All right, so the bar for entry-level performance does not change during internship. Every patient must receive appropriate care. Students will receive unsatisfactory scores in each stage of field internship. And the reason we don't lower it and for beginning students and raise for experienced students is very simple. We want to make for sure that everybody is treated the same. Everybody, when we get them out of orientation, they can function identical. So if you keep the bar the same, then obviously if you've got a more experienced clinician, you're probably going to wind up having to provide less prompting, which means that they're probably going to go through the orientation process quicker with certain skills versus protocols, which the experienced medic is probably going to require the same amount of prompting. Again, it kind of depends on the person and on the student, but you can't lower the bar. You have to treat everybody the same. And there may be times where, because of one error, this FTO scores the person a 0, and this is completely unsatisfactory performance. They didn't know the protocols, or maybe it just took them so long to do the assessment. You noted that respirations were inadequate. You must quickly initiate BVM. So this patient was in respiratory failure, respiratory rest, or essentially just not presenting with adequate respiration. And that student missed the fact that they needed to be doing a ventilation on the patient. Now, you need to document whether or not they accept responsibility or not. Do they give excuses? You said the EMT was talking too loud when I asked about the incorrect blood pressure. I have explained before that excuses are not acceptable. That is one thing that you're going to have to realize. Some people are going to live off of excuses, and you can't let them get by on that, because what you wind up with is an employee or a student who is very capable of presenting a compelling argument based off of an excuse, and what you have now is going to be a poor employee. All right, how might the FTO respond to some of these excuses? Well, I didn't know you wanted me to do what you should know. You should know, as a student, as an employee, you should be studying your policies. You should be studying your protocols. Well, my other FTO didn't do it that way. If I had $1 for every time I heard that my other preceptor didn't do it like that. Well, we're not going to discuss that. But what we are going to do is we're going to discuss the problem at hand, and at some point you're going to have to follow up with that other FTO, and go, hey, look, this is what this new employee said, or this is what the student said, whoever it was. You need to go back and talk with that preceptor, because maybe the preceptor did do that, and you need to find out what the rationale behind it is. Oftentimes, there may be times where we may modify our patient care or our patient assessment based off a specific situation. If you're doing an assessment at a call where there's been a patient has been assaulted, and the aggressor comes back, you may cut short that assessment and just get them loaded up and get going, because now the scene has become unsafe. Well, your student will forget to tell you that, because they're trying to cover their own butt. I was just going to blah blah blah. It could be there are time limits, and you've got to follow those time limits. For example, again, you got a chest pain patient or a patient in respiratory failure. You got to do stuff on a timetable, and you've got to do it within a relative quick amount of time. Where I came from, we didn't. And you need to that's going to be hard, because you got to understand the context of what they're saying. I can see two sides of this, and I've seen it in my career go both ways. Sometimes when your student or your orientee is saying that, they're trying to rationalize out in their mind why they are doing it different here versus where they came from. And it could be a logistic issue, it could be any number of things. So you have to figure out real quick, are they using it as an excuse, or are they using it as a way to try and change some of their patterns? Why evaluate communication? Well, um, along with their inability to make timely decisions and or they display unacceptable affective behavior, students' inability to communicate will be a sign of impending failure. Students who are at risk for failure are the FTO's biggest problem, and they will. And if you don't get it corrected early on, you're going to. This is just going to be something that's going to haunt you for a while. As you grow, as you know, you'll grow competent, more and more competent as time goes on as a student. Competent EMS providers are able to quickly gather information from a wide range of people, patients, family members, witnesses, and other things, and we're able to do it very quickly, and kind of get a global perspective of what happened. This ability to communicate is essential to providing appropriate patient care. Some people really have a hard problem with this, and it may be because of maybe this person moved from another part of the United States to North Carolina. Maybe they just moved from the mountains to the coast or some other part of the coast where something as simple as the dialect may be a little bit different, and they may be struggling with that. So when you're taking the communication aspect into factor, just look at whether they are local or whether or not they come from somewhere else, because it just literally just may be the understanding or comprehension of the English language. Now, there's just some people that they get focused in on a situation and they're very task oriented and they don't communicate well. That is something that you're going to have to work on your student with. So, the 10-90 rule. 10% of the students will cause 9% of your headaches. Primarily deficiencies of all students will be poor communication skills initially, and then that should get better. The failure to make good timely decisions, poor effective behavior, poor performance of physical skills. So these are going to be what you're going to see for your problem people. So if they can't communicate, if they're not making good decisions and timely decisions, and they're not making effective, they have poor effective behavior, and they just physically can't do the job, you really need to document it. Difficult students. They do require more time and effort. They require different teaching strategies. They may not make good employees, and they cannot learn. If they're kept in this, they are often kept in the system because of poor documentation, and they increase your stress level. They are not only going to be a pain in your side or in your neck, but they become a legal liability to you as well. So document the fact that you're having they're not receptive to the feedback, and these are going to be your patients who are going to be excuse after excuse, and they're going to quote. I've had employees and students quote things that weren't even so. Well, there's a study out there that says, all right, well, that's fine. Show me the study. Well, the policy says, okay, well, show me the policy. And what happens is they'll spend the rest of the day trying to find that study or trying to find that policy that never existed, that we don't know where it came from. Efficient student performance. When students are acting efficiently, they are moving ahead on three fronts. They should be able to get a good history, a good assessment, and be able to do well with the treatment of the patient. And it all makes sense. Why would they move ahead if they got all three fronts mastered, or they're kind of getting they're getting a better grasp of it? Well, You can't treat the patient if you don't have a good history and a good assessment. You can't treat the patient if you don't understand the disease process. You can't treat the patient if you don't understand policy, procedure, and protocols. So if you take those three things, there's a lot that you can grade out of it real quick. So some students do have trouble demonstrating leadership skills. Okay, we get that. So just kind of keep that in mind. It may be a self-esteem issue. It may be any number of reasons why they're having these problems. But to be efficient and to be an effective person or patient care provider, you need to be able to provide good patient care. They need to move forward on three fronts, and they do not work efficiently if they're not moving ahead. Again, we've already talked about that. Results from the student's ability to make decisions as far as good patient care goes. They've got to make good decisions. They've got to be able to multitask. They've got to be able to demonstrate good effective behavior. Psychomotor skills usually are not considered critical factors in here, but more as a team leader. Not everybody can intubate very well. Not everybody can start IVs very well. They're maybe mediocre across the board. But what happens if you can't start an IV very well? Usually your partner can. Now, am I saying if you as a provider don't do well practicing IVs, then that's going to be something you need to take some investment on and maybe try and get some extra clinical time yourself, or maybe encourage that student to pick up some extra time in the ED in a less stressful environment where they have plenty of opportunities to get sticks. Maybe if they're not doing well with intubations, maybe that your agency will allow that student to go spend some time in the OR. Psychomotor skills. What are we talking about there? Are they splitting the patient appropriately? Are they putting them on spinal immobilization correctly? Are they doing vital signs correctly? Are they actually listening to lung sounds? And do you go back and actually listen to verify that the lung sounds are correct? Medication administration. Are they following it based off of protocols? Are they just totally winging it? Rarely will students be unable to learn. Psychomotor skills. Prompts will speed up the learning process. Non-critical competency. They're not psychomotor skills are kind of a non-critical competency group, and until you become really good with it, it's just until the only way you can master it is just to keep doing it. And no skill is easy. Everybody look back at when you learned how to start IVs. It was a very scary thing. All right, note that there's no gray shading for non-critical competency. All right, prompts for non-critical competencies do not have to be counted. Interactivity. How are they doing their initial assessment? Listen to breathing. If breathing is too fast, how do I know if breathing is too fast or too slow? What is the 5-second look? So think about when you started off, what did you do as far as assessing a patient with initial assessment? Did you really know how was breathing too fast or too slow? Did someone ever take the time to explain that to you? Or is that something that you just come along over time and figured out on yourself? The 5-second look, that's the initial impression. Do they look bad? All right, circulation. How do I know if the pulse is too fast or too slow? 1001, 1002, how are you counting? All those are things that you're probably going to have to help them with, and those are things that you're going to also have to document. Okay. Verbal reports when you're giving your handoff. Remember, although this is a non-critical competency, you still need to document it because that could come back to kind of haunt you a little bit later on. If For example, some hospitals do trauma activations based off the fact that the patient was ejected from the vehicle. If they miss that during radio report to the hospital or during handoff, that could affect the amount of help or the level of response that the hospital gets. Competency 12 is the last competency group in the critique form. Provides complete documentation on patient report form. You know, how do we go about assigning an overall score on this? Well, in my view, and I'm sure there's going to be plenty of views out there, every EMS agency needs to have a documentation template. There needs to be a standard of how you're going to document an average chest pain call, a respiratory call, a cardiac arrest, just a general sick call. And when you're scoring this, you should be using that template. If your agency doesn't have a scoring template or documentation template, then you need to, in my opinion, you should probably encourage your agency to have one. That way, whenever you're doing quality assurance, you know to go get a piece of information from a certain area in that report on a regular basis. And it also helps you documentation verification with these new students. Our overall score. The FTO will assign either a satisfactory passing score or an unsatisfactory or a failing score to the patient contact. They will determine whether or not the student has received too many prompts during the contact, and if so, the patient will receive an unsatisfactory score. Satisfactory score is phase dependent. Instructional phase, 3 or fewer prompts. Evaluation phase should be less prompts. Should maybe be one prompt or no prompts at all. So it's going to be dependent of which phase you're in. In this situation, the student received an unsatisfactory score because the FTO gave 3 or more prompts during the instruction phase, and the FTO rated them again as unsatisfactory. So this is an example of when an FTO explains that the students received an unsatisfactory score as a result of repetitive prompting. The FTO's job is to provide instruction to an evaluation of the student. Notice the FTO's comments in the section. The FTO described the deficiency and suggested a plan of action for fixing the problem. The student has responded that he believed he could have implemented the correct protocol within the 3 prescribed minutes if the FTO had not prompted him, and the student may have been correct. Could the student's comments impact the scoring of this patient contact? Yes, it could cause the FTO to change the score from unsatisfactory to satisfactory if the student is correct. And that means that you FTO, you preceptor, you need to go back and review that situation in your mind and go, wait a minute, yeah, he was right, she was right. I acted a little bit too quickly and I kept getting in their way. So what you do next time is, in that same exact situation, is you sit back and wait to prompt until you absolutely have to. The FTO should require students to enter comments or indicate that they have no comments on each critique form. Students' comments will have more substance if an issue is addressed immediately. Complaints about scores that the student provides verbally and at a later time should not be considered. They may have merit, they may not. And again, you got to look at it. Are they using this as an excuse, or you know, how are they? What are they trying to do? Program managers should rightly respect the complaints that they receive at a later time. Maybe they're trying to justify why they had a underachieving score, or maybe it is because basically you as a FTO or preceptor, you're just not doing a good job. You're not allowing this person to function. Maybe you're a little bit overbearing. That most of the time that's not going to be the case. It's just going to be that student may be trying to use it as an excuse to get out of that poor score. If you're unsure how to score, what should you do? So here's some things you need to ask yourself. Were the actions of the student safe? Were they in a timely fashion? Were they appropriate, or were within protocol? And if the answer to all four of these questions are yes, then that is a satisfactory performance. If it doesn't meet one of these, was it unsafe? Then that does not meet expectations. You're going to have to go back and address that. So whenever you get something that doesn't meet the criteria, they perform unsatisfactory, you need to document. This is why I did not meet those expectations. What the student was about to do, what the employee was about to do, was unsafe. So therefore, they did not meet expectations. This is why it was unsafe. These were the potential actions that would have occurred had the student been allowed to continue. Same justification for timely, appropriate, and protocol. If you are still unsure about how to score, ask 2 or more questions. If this student graduates, could I work with him or her? If the student graduates, could she care for a member of my family? And that is something that us as instructors, us as leaders, because if you're going to be an FTO, then you're going to be a leader. You're going to be a teacher. And you need to remember that. These people one day are going to probably take care of somebody in your family. And you want to make sure that they're competent to take care of somebody in your family. Because all the rest of the time, who are they taking care of? They're taking care of living, breathing human beings who are somebody to somebody. They have family just like you have family, and everybody deserves the same right. They need to get good care from these students or employees. And if you feel like that you wouldn't want them working on your family, or you couldn't work with this person, then they don't score well. All right. If you treat my family member or work with, yes, maybe I'm scoring too hard. No, maybe I'm scoring too easy. Maybe I'm uneasy because there's an unacceptable behavior, but it's not occurring during patient contact. And that is very probable. Maybe they're not doing their truck checkoffs appropriately. Maybe they just, whenever you try and show them something in between calls, they're just acting like they're disinterested. So that is something that you need to document. You can't document it on that patient encounter form, but there are some things that you can do on the overall evaluation of what you saw during your downtime. All right, this is the end of this PowerPoint presentation. Hope you've enjoyed it. I know it's a pretty lengthy one, about 50 minutes. Part of your requirements for this module is going to be 2 things. First of all, you're going to upload into the discussion board a PDF copy, or a screenshot of your evaluation form for your agency. It could be for the community college, it could be for your EMS agency. If you don't have one, you need to come up with one. And the second part of this is going to be a two-part thing. You're going to also upload a template, a scoring template for every PCR. Now, I'm not saying if you've got 5 different templates, don't upload 5 different templates. I just want one. And if you don't have one, just create a generic template, scoring template. And maybe that's something that you can take back to your organization if you don't have such a thing, and work on getting some standardization with that. And make for sure that template, the scoring template, follows protocol and it follows accepted treatment guidelines. Thank you guys, and I'll see you guys on the next PowerPoint.